cold and his voice is a bit croaky, so I'm going to be managing the introductions. So I'd like to introduce Dr. Simba Mungazi. We are very honored to take him out of his busy schedule because he's back from the UK teaching in Zimbabwe at the moment. And Dr. Simba Mungazi, originally from Zimbabwe, pursued his undergraduate studies at the University of Zimbabwe, specializing in surgery. Since 2017, he has been a lecturer in surgery and anesthesia at the National University of Science and Technology in Bulawayo. In addition to his surgical expertise, he completed a 2-year breast fellowship in November 2022. He is currently serving as a specialist breast surgeon at East Cheshire NHS Trust outside Manchester, and he manages to balance his responsibilities by returning to Zimbabwe for teaching and for patient care. We appreciate Dr. Mungazi's willingness to share his insights with us despite his busy schedule. We are very honored to have you, Dr. Mungazi. We eagerly anticipate an informative academic update on the latest advancements in the surgical management of the most common cancer worldwide. The landscape of breast cancer treatment is evolving rapidly, and the initial diagnosis and referral by primary care doctors significantly impacts the entire cancer journey for patients. So we extend a warm welcome to Dr. Mungazi, who will provide updates on the latest developments. Joining him for the panel discussion are Dr. Celestine Mbangtang from Namibia and Dr. Munyaradzi Samson Magara from Bulawayo, Zimbabwe. So with that, I will open the session and hand the floor over to Dr. Mungazi. Thank you, everyone.
Good evening, everyone. I would want to thank you very much for those kind words of introduction, Dr. Stone. I would like to greet everyone and thank you for attending this very important session. So I will try and summarize as much as possible the surgical updates in breast cancer treatment. And I'm hoping for a lively discussion from the panel and the rest of the participants. So to start off, whatever I'm going to present tonight is not only because of my efforts, but there are lots of people and different facets of teamwork that has brought the amount of work or expertise that I'm going to present to you. And I would like to acknowledge the breast multidisciplinary team that's in Harare, but it covers most of cases in the whole of Zimbabwe. It's an online team meeting, and it's composed of all the specialties. I would want to acknowledge the Association of Breast Surgeons that gave me the opportunity, together with the Royal College of Surgeons, for me to actually train as a breast surgeon in England. And most importantly, I would want to acknowledge, my professor, Professor Godfrey Muguti. As a way of introduction, it's important that we understand that breast cancer treatment has evolved significantly. The reason why it has done so is because we now have a better understanding of the tumor biology. In other words, now we do have an understanding, of the tumor types of breast cancer, the immunohistochemistry, the use of Ki-67 and Oncotype DX. All this, knowledge has helped us in actually understanding how the tumors behave and what's the most probable best treatment for them. So for example, if I were to tell you that if a lady or a gentleman was found to have a lump and the histology after a core biopsy confirmed that it is a cancer, whether it's invasive ductal or lobular cancer, it is the tumor biology regarding on whether that type of cancer is actually triple negative, which will determine whether that patient will actually get chemotherapy or not. Long back, we used to rely on other factors why someone would get chemotherapy or radiotherapy or any other additional treatment. But nowadays, because of the better understanding of tumor biology, we are now at a better, stand in terms of what the patient actually needs. We used to routinely give all patients chemotherapy, but now we know because of the tumor biology, the measurement of the Ki-67, the grade of the tumor, the Oncotype DX, it can actually help us in assessing and actually having patients who don't need chemotherapy, being avoided at all. The advancement in radiological diagnostic and localization capabilities has changed over time. We now have what we call digital mammograms. We also have the 3D, or what we call the tomosynthesis. These, radiological advances have made it possible that even tiny lesions can be picked up. And not only that, it has also made it possible for us to actually localize these lesions, with the use of other gadgets like the MagSeed. And this does enable a surgeon to be quite specific and actually remove the area. New chemotherapeutic agents have also changed over time. The fact that breast cancer treatment now is a multidisciplinary approach has also changed the way we treat breast cancer. I will show you in a summary the technological gadgets that we are now using in breast surgery. One of the most important things, the reason why we are talking about breast cancer is because of patient care. Our customer in our business is patients. So the patient's expectations and demands have also made us change the way we treat breast cancer. I must say now breast cancer is actually an individualized care. It's no longer a one-size-fits-all. On the picture there is a gentleman, Bob Fisher, who did one of the revolutionary studies that actually showed that if one is offered a lumpectomy, if they had breast cancer, confirmed breast cancer, and they were offered a lumpectomy together with radiotherapy, the outcome was actually the same as one being offered a mastectomy. And that ushered in a lot of other opportunities in how we actually surgically manage patients. Decisions are more important than the actual incision itself. And there's no other better place that this statement can be applied than in breast cancer management. Nowadays, we do treat breast cancer after having had a multidisciplinary team meeting where all the parties are involved in the treatment, discuss the case before the patient has had any treatment. This, if it's done timelessly, it will actually give the patient better options. Individualized care. Nowadays, patients present with the different pathologies, with a different presentation, and they have got different expectations. And because of that, we no longer offer one-size-fits-all approach. It's important to know that the breast cancer treatment now differs from one patient to another. I will show you some latest technology and understanding of how we are now offering better treatment. But not all patients will want these fancy new things as far as they're concerned. If a patient prefers that they would want a mastectomy instead of a lumpectomy, then that's what we need to, understand and offer the patient. So the individualized care now allows us to offer patients a set of options that are safe oncologically, and the patient can then be part of the decision-making process, and they choose what they prefer. And that's the whole point of shared decision-making. Now, I will summarize what breast conservation surgery is. As you can see on that picture there, it's basically a lumpectomy where we are removing the disease with healthy tissue around it. And if we give radiotherapy to the breast, that we now consider as breast conservation therapy. For the past more than 25 years, that has been confirmed that it's oncologically safe. And patients who get a lumpectomy plus radiotherapy, they do fare well. They do well, just like patients who have a mastectomy. And in actual fact, studies have actually confirmed that patients who then have their breast, they actually have a better quality of life as compared to those who have a mastectomy. Breast conservation therapy is safe. And there are several studies that have been done, randomized controlled trials, that have confirmed this. Now, I will shortly discuss the technologies that are available. So what you're seeing on the slide there is a tumor, and in that lump, there's a small seed that has been placed. So that seed will emit a signal that's then picked up by that probe on your right-hand side. We use this technology to actually remove non-palpable lesions, number one. Number two, we also use this technology for those lesions that are palpable, but the patient requires neoadjuvant chemotherapy. And if they respond well, the tumor will actually disappear. And we actually place this seed before the patient gets chemotherapy. Then the surgeon will know where to remove the area of concern. We also use this technology to actually identify lymph glands in the armpit, the central nodes, for those patients with who present with early stage disease with clinically node negative on clinical examination and ultrasound examination. So we can use the probes with the use of the radioactive dye, or we could use what we call the Sentimag to actually identify the sentinel nodes. So these are parts and parcels of the new technologies and gadgets that we are now having. I must say that the seed has replaced the wire. Since the 70s, the wire had been a gold standard in actually localizing lesions. But now we know that the shortfalls of one having a wire, the patient will have to have the wire on the day of the operation, So it may actually delay starting the surgery. And for some units where the radiology department is at a distance away from the theater, a patient may actually walk around with a wire. Now, the beauty of having a seed placed is that the seed can be placed months before the operation, weeks before the operation, and this seed can actually be placed at the time of taking the biopsy if the signs are, or if the radiologist is confident that this is most probably a cancer. So instead of actually putting a marker, they could actually put the seed right away. And this seed can stay for weeks. So that actually cuts another appointment for the patient, coming back to having a wire on the day of the surgery. And as I've mentioned, there's no delay as compared to a wire that the patient has to have the seed placed on the day of surgery. So there are multiple advantages of using the seed in localizing lesions as opposed to a wire. This picture took it off from the internet. It does show the limitations of breast conservation surgery. Although we would have preserved the breast, but the outcomes, especially after radiotherapy, are not the best, as you can see on that picture. And this is on the left breast. This lady has had a wide local excision, a lumpectomy, and she has had radiotherapy. So what then happens is that because there was not enough tissue to cover the defect, the skin will then attach to the muscle after radiotherapy. The limitations of breast conservation surgery resulted in the birth of oncoplastic breast surgery. So this is a very busy slide. You won't be able to make any sense out of this. And it's purely intentional. I keep this slide for my colleagues, the general surgeons, because when I was training general surgery, we never used to think that the breast is complicated. So I always keep this slide to present to my colleagues, the general surgeons, to just warn them that, oh, well, things have changed, actually. There's so much that can be done on the breast, and one can actually be lost in the breast. So oncoplastic techniques have come a long way to actually address the shortcomings of breast conservation surgery. So during my training, some of the contraindications to breast conservation surgery are no longer so at all because of oncoplastic breast surgery. This slide shows how we can use a flap on the lateral aspect of the breast with the use of the intercostal perforators, and to actually then cover a defect on the lateral aspect of the breast. We do know that in small-sized breast women, B or C cup size, if they were to have a lesion which is confirmed to be breast cancer and you remove the whole area with healthy tissue around, there will not be enough breast tissue, to close the defect. In which case, volume displacement will not work, but what one needs actually to do a volume replacement. So we actually replace the volume with the use of the flap from the lateral aspect of the breast, which will be based on the perforators. This is a standard modified radical mastectomy scar that you see. I'm going to show you something interesting on how we have progressed from this. It's still a valid standard operation that we need to offer to those patients who come with stage 3, stage 4 disease. And so the techniques I'm going to describe have nothing to do with replacing this technique. Modified radical mastectomy still has a role for patients who present with advanced or stage 3, stage 4 or disease. Skin sparing or nipple sparing mastectomy have been confirmed to be oncologically safe in our patients. And so we could actually have a situation where a patient with confirmed breast cancer can have the whole gland removed, but the skin and the nipple be preserved. And that ushers in an alternative breast reconstruction modality where one can actually place the implant, the breast implant, above the muscle, the chest wall muscle, but just below the skin. In this regard, we then actually avoid mobilizing the pectoralis major. So you don't need to actually put the implant sub-pec. With this new technique, you can actually put the implant just behind the skin and not the muscle. Having said that, because the implant may be exposed by just having the skin covering it, there's actually a solution to that where you actually use a mesh to cover the implant and then slip it under the skin and offer the patient an immediate skin sparing or nipple sparing mastectomy with an immediate implant reconstruction together with a mesh. And this is oncologically safe. I will summarize about 3-4 cases that we've managed in Zimbabwe with this new latest technology. So I'll start with the 69-year-old lady that we actually offered surgery actually offered this lady this surgery this Monday. And I saw her today for review. She is doing very well. She's a 69-year-old lady, fit and well, diabetic. On medication, she had a symptomatic lump at the 12 o'clock position that measured 2 centimeters, confirmed on mammogram and ultrasound scan in her left breast. The core biopsies did confirm that it was an invasive lobular cancer, which was ER/PR positive. HER2 was negative. Sorry about the typo error there. The HER2 was negative, and the Ki-67 was less than 5%. And this invasive lobular cancer was actually a grade 2. It had associated DCIS, which was high-grade DCIS. You can actually see the mammograms there. And on the mammograms, on the MLO view, you can see the lesion there. And then on the CC view, you can see the lesion and a clip marker there. An ultrasound scan of the left axilla was normal. She had no complaints of the contralateral breast, and imaging was normal. Because this was invasive lobular cancer, this patient had an MRI breast, which then confirmed that indeed there was a solitary lesion. So we're not dealing with a multifocal or multicentric or bilateral disease, and that it will measure 2 centimeters. We are aware that with mammograms and invasive lobular cancers, that they can be sneaky. So sometimes the actual size may not be confirmed on ultrasound and mammogram. We offered the lady the treatment options, and she preferred to have a lumpectomy and central node biopsy with the use of the Santimag. She's aware that she will need to have radiotherapy. after surgery. But if we have enough time, I'm happy to discuss this case further on the role of radiotherapy vis-a-vis the Prime 2 trial. Yeah. This lady could actually potentially avoid radiotherapy. But that's another discussion for the panel and the rest of the team. So we offered this lady a lumpectomy. This is in Zimbabwe. We did this operation on Monday. So what you're seeing there on the slide is actually the lumpectomy. We've removed the tissue and we've marked it with the sutures and the clips. We have done a mammogram intraoperatively, and that has confirmed that what you see there, the clip, one clip, that's the superior margin. The 2 clips are medial margin, and then the 3 clips are the lateral margin. So this will make this area an inferior margin. So the radiologist, thank God we do have breast radiologists in Zimbabwe, confirmed that the inferior margins may be involved. As you can see with the picture, then the photo in the middle, and the drawing there. So we had to do a further inferior cavity shave, as you can see on the other picture there. We then used the Sentimag to identify the lymph glands. So I actually injected 2 ml of the mag trace, which is iron particles, and I injected it a day prior to the surgery. I could pick the signal. So with that probe, if you can see on the first picture there, that's the probe, which is pointed into the axilla. And on the console there, you can actually hear a sound. Sorry, I don't have the video at the moment. And there'll be a pickup rate, and you can actually see the figures going up, and they'll actually confirm for you that you're actually in the right direction. And on the last 2 slides, I've actually removed the sentinel node, and I'm actually confirming the count and recording it. The second patient is a 57-year-old lady, fit and well, on antihypertensive treatment, who had a symptomatic 2-centimeter lump at the 12 o'clock position in the right breast, which was confirmed as well on mammogram and ultrasound. She had a biopsy, core biopsy, that had then confirmed that it was a grade 1 invasive ductal carcinoma of no special type. The cancer was ER/PR positive, HER2 negative, LVI, and lymphovascular invasion was positive. An ultrasound scan of the right axilla showed 1 node that had increased cortical thickness, and the biopsy then confirmed reactive node. The lady was discussed in the multidisciplinary team meeting, and she was offered the options as noted there. She preferred to have a mastectomy and a central node biopsy. And in this case, we actually did not have access to the Sentimag because we did this operation at a different center. But just to show you that we managed to actually get the central nodes by using the methylene blue dye. And the pictures there actually show you the methylene blue dye in the lymphatics, and us actually identifying the lymph, the central nodes. And you can actually see the 4 central nodes there. And this shows how versatile that, even though we have the access of the Sentimag, we may still be able to use the methylene blue dye. And the third case is of a 64-year-old lady who had a symptomatic 1-centimeter lump, 2 centimeters from the nipple in the right breast. A core biopsy, she had mammograms, ultrasound as a standard of care, and the core biopsy did confirm a grade 2 invasive ductal carcinoma of no special type, which was ER/PR positive, HER2 negative. And the ultrasound scan of the right axilla was normal. Her left breast was normal. This lady is known to have diabetes, hypertension. She's on ARVs, and she sometimes suffers from neuropathy. I must say she has a high BMI, Her BMI was about 35. And the lady did not want radiotherapy because we had offered her a lumpectomy. And because she was aware that if she were to have a mastectomy, she could potentially avoid radiotherapy. She puts on a double D bra cup size. So we then offered her a Goldilocks mastectomy and central node biopsy. We'll then offer her a contralateral breast reduction for symmetry at a later stage. So I'm going to show you the pictures. So what you're seeing on the picture there is actually the lady with the marking there where the cancer is, and it was about 1 centimeter. She's a double D bra cup size. So these are pre-markings before surgery, where we are marking as in a wise pattern fashion, which is quite familiar with the plastic surgeons. And what we are offering for this lady, what a Goldilocks is, we are actually using, we'll offer her mastectomy, but we'll preserve her skin and fat to make another breast mound. So intraoperatively, we are now de-epithelializing the lower portion, the lower half of the breast. You can actually see the nipple there, and the patient's head is this side. And then we have removed the breast tissue. Sorry, we have removed the breast tissue, and in this case, we also use the methylene blue dye. And then we use the lower portion of the de-epithelialized skin to form the breast mound, and then we cover. So what you see there is on the table. That's the final, picture. And this is, I took this picture 2 weeks after the surgery, and the lady has done very well. So as I've mentioned, we have actually removed the whole breast tissue, but we've used the skin and the fat that the lady has to make another breast mound. Then we'll then offer her a contralateral breast reduction at a later date when she has finished her cancer treatment. The last patient is a 69-year-old lady who's fit and well with a symptomatic right breast lump at the 9 o'clock position, which was also confirmed on mammogram to be 4 centimeters. That's the size of the mass, but it also had an area of calcification around the mass, increasing the area to 6 centimeters. As you can see on the mammograms there, I don't know if you can see if my pointer, that's the area of concern. There's a clip there. It's easier seen on the CC view. The lady had a core biopsy, which confirmed a grade 2 invasive lobular cancer, which turned out to be triple negative. The right axilla at the time of presentation was normal. The lady was discussed in the multidisciplinary team meeting, and she was offered a neoadjuvant chemotherapy, and she had a breast MRI after 16 weeks of cycles of chemotherapy, which showed a partial response. This lady puts on a C-cup breast size, bra size. And this is the type of patient that I showed you the picture, where once you remove the area of disease, the volume of disease that you remove, there won't be enough breast tissue to actually, offer this lady a breast conservation surgery. There's not enough breast tissue to do volume displacement. So this lady would have been a candidate for a mastectomy in the era where we were doing breast conservation surgery only. So those are the pre-op pictures. So you can see the markings there. This is the area where we had the 4 centimeter area of disease. We intended to remove that whole area in surgery, and we'd all pre-marked the flap that we will use to actually do the volume replacement. Yeah. And in theater, we then confirm the perforators with a handheld Doppler scan. Yeah. And we then proceed to do a lateral incision where we actually mobilize the breast tissue and do a wide local excision from the mastectomy plane down to the pectoral fascia or muscle. So you can actually see that huge cavity. And there was no way that one could actually close that cavity with the patient's own breast tissue. What you also see that on the lateral aspect, we've actually de-epithelialized the skin, because that's where we are going to harvest our flap, and we'll flip it into the defect. Yeah. And we have removed, that's the picture of the specimen. It weighed about 90 grams. We did an intraoperative mammogram, which showed that the calcs were actually extending to the medial aspect. So we actually had to take some more, and we did a medial cavity shave and a lateral cavity shave. So we actually see the clips there. And these two are images are of the needles that are fixing the specimen to the board. We were not worried in taking some more tissue, because we knew that we had enough, volume replacement tissue to cover the area. We, as routine, did a sentinel node biopsy with the use of the Sentimag, and you can actually see the count, and one of the nodes there did a high count. This picture shows us mobilizing the flap, and then us actually flipping the bag into the defect. Then we closed the incision. So the incision has been the lateral aspect. And if you were to view the patient from the anterior view, you won't even see the scar, and you won't even tell that they've had surgery. So this was just a few minutes after the patient had had the surgery. We do leave a drain that we then remove later on. And the drain, we place it on the donor side, not on the recipient side. So in conclusion, surgery in breast cancer treatment has evolved and is still evolving. Breast MDTs, multidisciplinary team meetings, shared decision-making, individualized care are crucial in the management of or treatment of breast cancer. Oncoplastic breast surgery and breast reconstruction must be part of the conversational discussion in breast cancer care. Oncoplastic breast surgery and breast reconstruction for breast cancer treatment are feasible options that we are now offering in Zimbabwe. I'm happy to say that I have my colleague, Mr. Munyaradzi Samson Magara, who trained in oncoplastic breast surgery in England. And we are hoping that more will join us in this journey. Thank you very much.
Thank you very, very much, Dr. Mungazi. That was a brilliant presentation. I've seen it before at the Zimmer house, and it was just as impressive tonight. I want to, I'd like to ask a question to start off with, and I'd ask it to the panel, which includes Dr. Mbangtang and Dr. Magara, or sorry, Mr. One of the things that has become clear, I mean, I qualified in 1989, at which stage radical mastectomy, axillary clearance, chemotherapy was kind of the standard for every breast cancer patient. And these days, 85% of breast cancer patients over 50 who are HR positive, HER negative, and have no nodes don't need chemo. So the histology is obviously critical, and the staining and the tumor markers are very important. So the first question I'd like to ask you is, where do you get those done? Can they be done in Zimbabwe, or are we sending them away? And the second question I'd like to ask you, which came up at the Zimmer meeting, is sampling of 4 nodes as effective as axillary clearance? And I'd put that to the panel. Let's start with you, Dr. Mungazi.
Thank you very much. So we do offer immunohistochemistry routinely in Zimbabwe. It would have been good to have a pathologist answer that question, how they do it. But I have not had any problems with patients getting their immunohistochemistry here in Zimbabwe with the different labs that are there. Number one. Number two, I thought your question was going to be, I'm sorry, but it may still be the same. You are saying, is there a difference between sampling? Are you comparing 4-node sampling? Are you comparing it to the standard sentinel node biopsy technique, or you're comparing it to axillary node dissection? Before I answer.
I'm comparing it to what I was taught, which was a complete axillary clearance, so axillary dissection. So is 4-node sampling as good as an axillary clearance? Because we saw a lot of patients in the 1990s with very, very bad lymphedema.
Okay, so what happens is, I think it's comparing apples and oranges. So for a patient who presents with breast cancer, confirmed breast cancer, and clinically involved nodes, that patient requires surgery in the form of axillary node dissection to the axilla. I'm aware that if we have oncologists on the floor, they may say, no, we are now just giving radiotherapy to the armpit. I agree with that as well. But if a patient comes with a clinically palpable, suspicious, and confirmed, involvement of the axilla, that patient requires an axillary node dissection. Like what you were seeing them being done in the 80s, Dr. Stone. That's number one. If a patient were to come with early stage breast cancer, and they've been confirmed to have a cancer in the breast, but clinically the armpit is clear of disease and is confirmed on ultrasound scan, that patient is a candidate for a sentinel node biopsy. Yeah. So with the sentinel node biopsy, the gold standard has been to use 2 agents, a patent blue dye as well as a radioactive dye, which has been done world over, and that's what we have been trained to do in England. But with the use of the new advent use of the Sentimag, we can also use that Sentimag because it gives you the sound and it gives you a change in the color. So those have been the ways of doing the sentinel node biopsy. Now to introduce the 4-node sampling. So 4-node sampling was first done by, may not have been first done by the guys in Edinburgh. There's a guru in breast there, Professor Mark Dixon. So what Professor Mark Dixon and his team in Edinburgh did was they were doing 4-node sampling, which is defined as when they actually do when they do surgery for a patient with confirmed early stage cancer with no palpable or involvement of the axilla, instead of offering the patient the sentinel node biopsy technique with the use of the methylene or patent blue dye and the radioactive dye, what they would do is they would take the patient to theater, they would explore the axilla, and they would just take 4 nodes, and they call that 4-node sampling. What they found from that study is that the 4-node sampling was as good, as the standard way of doing the sentinel node biopsies. So in a country where we have resource limited, where we can't have the radioactive dye, where we can't use the Sentimag, or for some reason we can't have the methylene blue dye, we can safely do a 4-node sampling in those patients with early stage breast cancer, and the results will be the same, hopefully. But that will be in good trained hands, because you may not be able to find those lymph nodes in the axilla if you are not well trained to identify them. So 4-node sampling will be ideally for those patients who are early stage, and patients with confirmed involvement of the axilla will still require axillary node dissection. Thank you.
Thank you very much for that, Dr. Mungazi. I'd actually also like to ask Dr. Mbangtang about the research that he's done in Zimbabwe, because I wasn't aware that you had worked and lectured here. So, Dr. Mbangtang, can you tell us about your Zimbabwean experience?
Oh, okay. Thank you, everybody. Yes, I pride myself to have started a immunohistochemistry in Zimbabwe. This was in we did that in it was over 2 years, 1998, 1999, and we put everything together in 2000. Well, before then, immunohistochemistry was done for breast cancer at cytosolic estrogen receptor assay. So we started that. Luckily enough, it was part of my dissertation for the EBMed in general surgery. And Makunike, then Dr. Ma is a professor, she's a professor now, was very interested in the study because where she trained in the Scandinavian countries, she said there was somebody who was interested in such a study in Zimbabwe. And luckily for me, there was Hole, a German pathologist who was in Harare then, and he had experience in immunohistochemistry from paraffin embedded tissue. And that is how we started the immunohistochemistry assay for breast cancer in Zimbabwe. That was my dissertation, MMed dissertation. And from then, I was taking the breast tissue both in Harare Central Hospital and Pararenyatwa Hospital, doing the cut-up myself in Pararenyatwa, and we're trained to do I used to call it cooking because we're passing through microwave and everything, and doing the staining. It was quite interesting. As we were going on, then in the private sector, they started bringing their tissue to be done there. And that is how we started immunohistochemistry in Zimbabwe. Yeah, that is what we did. And it was quite interesting. I'm still happy when I talk about it, because that was the first time we were doing immunohistochemistry in Zimbabwe. Just from, well, we got got a good support from Norway, because we're getting all the chemicals from Norway free of charge. Well, was somebody paid in Norway, but we didn't use money from our pockets to do that. So this is how immunohistochemistry started in Pararenyatwa and in Harare. Well, coming back to what Simba was saying, let me just chip in on the question of axillary sampling and axillary dissection. Yes, it is true. Axillary clearance gives a lot of complications, including lymphedema of the ipsilateral arm, which may eventually could change a breast cancer into a lymphedema and sarcoma of the ipsilateral side. So axillary dissection, and because of the improvement in chemotherapy, improvement in radiotherapy, we do axillary clearance is actually not advocated because of the consequences of that. However, I may also say Simba talked a lot of beautiful things done there, but in this day and age, there is no excuse if we have to do sentinel. Somebody qualifies for sentinel lymph node biopsy. There is no excuse because simple methylene blue dye could be used. You may not necessarily need the isotopes because you need the isotope with a Geiger counter, that's fine. But a simple methylene blue dye, which we use extensively in Francistown in Botswana, if anybody who is doing breast surgery should be able to do that. Simple methylene blue dye infiltrate around the tumor and the areola, then intraoperatively, then you see it traces, you actually trace the lymphatics to the axilla, very clean. What I'm trying to say is, in this day and age where we are moving forward with breast conservative surgery, there is no, when somebody really needs sentinel lymph node biopsy, anybody doing breast surgery should be able to advocate for those things to be done, because it's very simple. Methylene blue is, it costs less to nothing to do it. I think I will stop there to give room for the other panelists to intervene.
Thank you very, very much for that. I'd like to ask Dr. Magara about breast cancer management in Matabeleland and Bulawayo.
Okay, thank you very much. I should acknowledge that that was a brilliant presentation by my colleague, Dr. Mungazi, and a big, quite a concise summary of what it is regarding today's breast surgery. No, well done. Right, I'll just go through a few points before I talk about breast cancer management in Matabeleland. Right, just to go over what Dr. Mungazi said. It's really reiterating the points that he has made, that breast or management of breast cancer these days is bespoke. It is tailored to the needs of the patient, and that is based on the biology of the tumor as well as the staging. So, and all this has to be in the context of a team that consists of surgeons, pathologists, radiologists, oncologists, and the nurses and other support staff, who may be involved, psychologists and palliative care managers. But importantly, management of breast cancer is based on team effort, and the management for each patient has to be based on the biology, and the histological type of tumor, as well as the receptor status, and that coupled with staging. Right. Then comes to the issue of breast conserving surgery. Like he rightly mentioned, that for early breast cancer, the management with a breast conserving therapy, which is lumpectomies or other breast conserving surgery plus radiotherapy, the outcomes in terms of survival are no worse than mastectomy. So that is, that's what it is now. But having said that, it is always important to remember that in a place where we may have high volume disease, we have to be very careful and be conscientious in our management of the oncological aspects over cosmetic aspects of the outcomes of our management. So in other words, we shouldn't sacrifice the outcome in terms of, the margins being positive or, so close in a bid to preserve the appearances of a lady. The women or, the patient has to be really counseled around the implications of what it is, depending on now the stage, the size of the tumor relative to the size or the volume of the breast itself. And he touched something on sentinel node management, the practice or the technique of sentinel node. He gave examples in the cases of the use of the methylene blue, which is what is common, as Dr. Mbangtang has said. But the standard, as he rightly mentioned, has been based on the isotope alone or together with dye, blue dye, particularly in ladies who have a higher BMI, because the axilla there, it may not be easy to pick up the signal through a wad of fat in the armpit. So the methods of tracing, are ever improving now. We have the isotope, we have the blue dyes, which may be, based on the methylene, but also the patent blue dyes. And now we have MagTrace, which is a super para magnetic oxide based, and we use magnetism. And then with neoadjuvant patients, there may also be, apart from the mag seed, we can also use pintuition seeds. We can also use carbon marking or carbon dyeing of the involved nodes. And he gave a quick summary on the ongoplastic techniques and the use or the consideration around the skin envelope if you want to do reconstruction. I won't add much to that, but around the oncoplastics, the volume considerations that have to be made is, in respect to the breast size, we need to have consideration of the bra size, in terms of, our decision making, but there's also issues of doses and, what the patient wants. Do they want their breasts to remain big as they are, or they want them reduced? And so if a patient has got a large breast and they want them reduced as part of the treatment, that brings the aspect of therapeutic mammoplasties, and that can be given to the patient. And for patients with small non-ptotic breasts with relatively large tumors, they can have the volume replacement. Whatever you take out from the breast, you want to replace it by tissue from somewhere. And usually we make use of local perforator flaps. Yeah, so yeah, that's about it. And then lastly, about the 4-node sampling, right? Yes, in good hands, in people who know how to identify the nodes, it can be, quite a sensitive procedure to do, and you may be able to pick, the sentinel node, so to speak. But, this technique may not be as sensitive as one where you actually either trace by use of isotope, where you use sound, or we use your vision by the blue dyes, or sound and vision as in MagTrace. Look, the reason why we need these tracers is because our senses are not as, they need augmentation. So yes, while the 4-node sampling is a good technique, but it cannot be as sensitive as where you have augmentation of the senses by, either vision or the sound. So yeah, that's my comment around the 4-node sampling. It's good where you don't have things, or if the patients have got maybe an allergic reaction to the ice, to the dyes. Yeah, surely you can do it, but if you have the dye or the isotope, then it's better to use it. Right, now, coming to Matabeleland South. It's an area that, in terms of resources, is I think lagging behind for diagnostic equipment. We do not have a lot of equipment as they would have in Harare. Mammographies, we have 2 at the moment, 1 recently installed, but both are in private. we don't have any in the public sector. We have a shortage of radiologists. They do have in Harare as well, shortage of radiologists, but I think ours is more acute. So what we are trying to do, what we have done is to try to use the local and available resources, manpower first. So I went for training, as you heard from Dr. Mungazi, in breast surgery, but while I was there, I also took sessions to learn ultrasonography of the breast, and that is a very invaluable skill that, I didn't realize how important it was going to be, but it has turned out to be, a game changer really in the way that we manage our cases. Because when a patient comes, I'm talking of the public sector, when the patients come, it's not all of them who can afford to go across to the private side to have mammography. And it's not all of them who can afford even to wait for the booked ultrasonography sessions. So when they come, we examine them, and I'm able to do the ultrasound scan while they are there in the clinic. And if, I'm convinced that this patient, what they've given me in the history and what I see on the ultrasound is so suspicious, we can actually offer them biopsy in the same sitting, in that same one clinic, and take the sample. And then the following, when they come, they're coming for results. And we've managed to do diagnosis within a week or two for most of our cases. So in terms of the diagnostic service, that's what we've managed to do in Matabeleland. Of course, there is the help which we get where it's not possible to make this quick decision. I've got the two radiologists who are resident here who, I call upon for help, but it's not many times that we've had to do that. So that has really significantly helped in cutting time to diagnosis in our region. So I think, that's what we are doing. That's what we are implementing at the central level. And we're trying to extend this concept to the peripheral hospitals which feed into our hospital by teaching some nurses the basics of examination of the breast, and so that when they see patients, they don't just send them, saying go across to Bulawayo. They can examine them. And some of the nurses, they've actually also, or they are actually undergoing some training in ultrasonography, because we don't have radiologists, we don't have radiographers out there, in the districts. There are none. So we have to make use of what we have, and we are doing that. So the nurses are being trained. We are helping them to be able to identify, or at least just to take the image. And then they send the image, and we discuss the image. And if the patient has to be referred, if the patient has to be referred, they are referred at least knowing what they are coming to the central hospital for. So if they are coming for biopsy, at least we have an idea that they're coming for a biopsy before they come, and they come prepared. So yeah, in summary, that's what we are doing in the Matabeleland region for breast management.
Thank you very, very much, Dr. Magara, for that. One of my interests, and one of the interests of DMD and STM in Bulawayo, is point of care ultrasound. So I may be contacting you and seeing if you would be willing to do some training, because I think that our vision is that people at the point of care, whether they be nurses or primary care physicians, that they are able to do an ultrasound, even if they are just able to identify whether a lump is cystic or solid. So I think that would be a huge move going forward. I'd like to ask a question from the chat, and it's from Marissa Torero. She says, can you provide insights into the psychosocial and emotional support that breast cancer patients may need during their journey?
Okay, is this to me, or is to the other panelists?
Whoever comes in on first.
Oh, okay, fine. Yeah. Right. So Yes, the journey for a patient who has got suspected breast cancer, it starts from there, from the point that they pick a lump in the breast. And, it's they come, and sometimes if you are, you just open to it, you can actually ask them, and you know that what they tell you about the kind of anxiety that they have, the lack of sleep that has visited them since they first saw the lump. And this is worsened if, when you have examined them, you actually show that you are suspicious as well that this could be malignant. So there's a lot of anxiety that eats up our patients, and it has to be addressed. The patient needs assurance that whatever is found, and particularly if it's found early, we are able to help you. They need that assurance even before the diagnosis is made, right? And where it's possible, nurses are of great help to be behind and to support these patients. We have in our setup at the UBH nurses who have done basics of breast care, breast nursing care, but it's not enough. As now we are realizing, I think they need more of a hands-on in terms of counseling, in terms of just working with the patient and giving information. Because one of the things that we've noticed is that, I think it's human nature. You gravitate towards the worst that it can be. And this information that scares our patient the most is found on the internet. So they just go to any site that comes, they just Google, and then the information comes. But you see, remember, we say the breast cancer treatment now is bespoke. It's according to the stage and the biology. So unfortunately, the information that they get may not fit in well with what their condition is in truth. So it's an area that needs attention. I don't know what the experience of other colleagues has been, but for the time that I've been here, I've realized that we need nurses who are well trained to take care of the emotional needs of the patients.
Yeah, thank you, Jackie. But let me just chip in. I actually started a breast clinic in Francistown in Botswana, which is a government center, and it is still running. And the breast clinic, we had dietitians, we had oncology nurse, we had a palliative care nurse, and we had a social worker. Then they were run by 3 surgeons with this team. Of course, the oncologist and the radiologist were part of it. And it was once a week, and it was a Wednesday, and it was a one-stop thing. Patient comes and diagnosis is done, mammography is done same day if the patient needs mammography, ultrasound done same day, and later the MRI was just done, not in every patient, just few selective patients where we had problems. It was a one-stop thing. I would not like to be a nurse in this era where everything that we can do, we throw on the nurse. But there are psycho-oncologists now. There's a psychologist who are specializing in oncology. So they're psycho-oncologists. And there's an African psycho-oncology group. I think it's doing more in Nigeria, but we have members in Namibia right now. As I'm talking, my daughter is just finishing a master's in psychology, and her dissertation is psycho-oncology, and it's on breast cancer in the Windhoek Central Hospital. What I'm trying to say, this multidisciplinary team should also include a psycho-oncologist where possible. And we need psychologists to train in psycho-oncology, because the journey of a patient with a small breast cancer or a stage 3B or 4 breast cancer at the beginning is the same. There's psychological challenges. Just a nurse or a surgeon or a nurse who is not schooled to handle this may not handle this appropriately. So as we navigate our journey on breast care, we should also include psycho-oncologists into the breast care team. Mungazi and your colleagues at Matabele, I think this is my thinking. I think the way to go is also to really have breast clinics with all these people involved in the breast clinics. I like the way they're going in Matabeleland. They're trying to make everything easier. But as we're talking, nurses are also trained. There's Jenny H. from Cape Town. They produced a very nice book for nurses. Jenny did some training of nurses in Zimbabwe, done the training of nurses in Botswana, done also training of nurses in Namibia. And the book is, they've changed it, they've revolutionized it, they've changed the book, and they are still ready to come in. You guys in Matabeleland, I'm very happy for Jackie's study thing. There's also Breast Interest Group of Southern Africa. Please join BIGOSA. It's a very good forum for all of us who are interested in breast care. And lastly, College of Surgeons of East, Central, and Southern Africa, we are finalizing the curriculum for breast the surgeons. It's a 2-year curriculum done after fellowship, both for plastic surgeons and general surgeons. We're just finalizing the curriculum. I will get further discussions by this December, next month. Yes, in Addis Ababa. But the curriculum is finalized. It's just to determine the number of cases a candidate should have done and what to do before sitting for the examination. And he also involved the guys from the UK and Ireland, the Irish and we are also trying to get the BIGOSA people to put an input, because the South Africans are also interested when they heard that COSEXA is starting this breast training. They've been struggling to start it, but I don't know why. But this is just information, and we need to do the finalization is getting the criteria for training sites and the number of cases for candidates to do. But I'm very happy you mentioned breast ultrasound. Any surgeon doing breast surgery should be able to be trained to do his or her own ultrasound scan of the breast. In my clinic, I have a butterfly. Okay, I say in my clinic, I have a breast clinic. I have a butterfly from a butterfly thing, which I do with my breast ultrasounds. Yeah, so I'm trying to say every breast surgeon should be able to do his or her own ultrasound scans of the breast. So this is, I think this is the way to go. Thank you, Jackie and Intellectus, for bringing this together. And Mungazi will tell me where he is, because Mungazi is very elusive. Okay, I hand over.
Thank you, everyone. I'm sorry I dropped off there for a minute. We had a power cut, which I think is not unusual in Africa, but I've managed to switch over to an alternative way of connecting. So thank you, everybody. That was an amazing meeting. And I hope I certainly learned a lot tonight. And I'd like to thank all of our panelists and also Dr. Simba Mungazi for a brilliant presentation. And hopefully our next presentation will be on teaching GPs and nurses how to ultrasound the breast. So thank you very much, everyone.
Thank you.
Thank you, Jackie.
Have a good evening, everyone.
Thank you.
Thank you.